Travis go since he's been away for a while.
All right. You guys can hear me?
Can you guys hear me?
Yeah, I can hear you, Seth.
Yeah.
Okay.
I don't see a screen invite yet.
It's not letting me send you one. It says you already have control.
Oh, well then I'll take control. See if that works.
Yep, we're good.
All right. Yeah, it's been a few weeks. I've got a couple of interesting cases here. This is one which something I hadn't seen before, and maybe you have. I know after talking to Sanjeev, he has seen a couple of these cases. This is a young woman who, for whatever reason, ended up with a CT last year, and I don't know the cause or the reason why. And she was found to have this vascular abnormality in the right lower lobe. And this was originally referred to our HHT center, one of our interventionalists that treats a lot of arteriovenous malformations, because it was uncertain if this was a pulmonary artery aneurysm, whether this was an AVM. You can see there's some large bronchial arteries here, or what exactly this was. So on this more of a venous phase imaging, it's not really, I think, that helpful. You can see the pulmonary artery here. This looks like it's coming off of a branch. Then you also have this here, which is slightly different attenuation, unsure of what it was connected to. This is the study I saw. This was also from the outside, but the interventionalist asked me to look at this. And you can see there's different attenuation in this area now than there was. And this is clearly part of the pulmonary artery. And what's interesting on this case that I saw was this little puff right here. It looked like a little bit of smoke going into this. And so, this actually, I have a different series as well, and you'll see is a bronchial artery. So the bronchial artery, actually you could see it better on the old studies, but there is a little difference in attenuation between the bronchial arteries here and the pulmonary artery. And this is actually a 50 keV, but you can see how this looks more like bronchial artery, and then wondered if there is a bronchial artery or pulmonary artery fistula based on that little puff of smoke right there. So we talked about doing an MR. They wanted to avoid doing catheter angiography to confirm it. So I did a CTA, much like this paper. And this was a case report that we cited in our smoke paper a couple of years ago, where in this case, it was a bronchial artery to pulmonary artery, communication that was simulating pulmonary emboli. If you can see, some of you, I know Howard, Jeff, and Seth have seen this for sure. You can see the inflow of unopacified blood mimicking a PE, which is just smoke from the bronchial artery. And so they did repeat with a saline flush or saline chaser to flush out the pulmonary arteries. And so I did that in this case, and you can see for sure here now there's a little bit of a positive puff from these bronchial arteries that are lighting up into this pulmonary artery. So question for you is how many of you have encountered just spontaneous pulmonary artery to bronchial artery fistulae with aneurysms like this? And you can see how this right lower lobe pulmonary artery is actually higher attenuation than the rest of the pulmonary arteries because of this shunt. This woman, you can see there's no underlying airway abnormalities or other structural abnormalities. I report she did have a history of a severe pneumonia as a child. We don't know if it was in the right lower lobe, but I wonder if she ended up with a fistula as a result of that. So has anyone seen something like this?
I haven't.
I'm not.
So Sanjeev said they've seen a couple at Mallinckrodt, and that one of them presented, very similar young patient that presented with massive hemoptysis. So this lady hasn't had any hemoptysis, but there's still some, fear that this should be dealt with or intervened upon. But I have not encountered this before.
Yeah, no, we see it all the time in our CTEPH patients, but it's not an aneurysm. It's just drainage. You can see it shooting in like that last paper, but I've never seen
that. But this, like the PA here, that's why I wonder, did they have like a mycotic pseudoaneurysm from a pneumonia that kind of healed, but happened to heal with a fistula? I don't know. That's the
they could have put in a Swan-Ganz and injured something. And who knows? That's really interesting.
But I thought it was an interesting case of smoke, and also it was kind of fun to do this just do 50 cc's and then flush to get this difference between the systemic and pulmonary artery flow. So I don't know. I'll let you know what happens, because the interventionalist is seeking other opinions on whether or not this should just be watched, or how big of a risk it is of having spontaneous, potentially life-threatening hemoptysis.
Very interesting.
Okay, this is a disease that came about last fall and really never got its due. This is the first and only case of it I've actually seen in this context. If we can think back to the pre-COVID and pre-vaping days where there wasn't that much news, the first of these press releases that came out on the STR website, of which some of us were involved with, was this. This is a 50-year-old man, and you can see that he has perilymphatic nodules, some of them more coalescing into these areas in the upper lobes. There's no, there's certainly an upper lobe gradient. He has a little bit of mosaic attenuation. I'd be curious if he has air trapping. We didn't do expiratory here, but it's certainly clustered in a perilymphatic distribution. There's no calcification. He does, well, maybe a little bit of calcification in the lymph nodes. But this is a 50-year-old, and his history is significant for being a stone, a worker at like one of these artificial stone countertop production facilities. And he's been there about 12 years now, and ventilation's terrible. He rarely uses a mask. And apparently he's one of, a handful, more than one case now of accelerated silicosis in these stone workers. And so this is the first one I've seen. I know, Jeff, wasn't it out of Australia that they had a big piece on the resurgence of this?
Yeah, YouTube thing about it.
You're a week late, so I think Dave Godwin showed an amazing case last week.
Yeah,
Oh, really?
Yeah, I hadn't seen a case. He showed an amazing case.
Travis, what was interesting is David's case, he had some serial imaging, and it was amazing how fast it progressed.
Yeah.
Yeah.
Here's I pulled up the STR press release from last year, and this guy fits he's a little actually older than the mean age, but exposure mean of 12 to 13 years. Some of them have been reported in California, I guess Washington too. So sorry I didn't get to watch last week's broadcast yet. But yeah, just a nice, typical example of upper lobe predominant perilymphatic nodules. I mean, without that history, I'd be thinking sarcoid, but pretty strong history for this. And he's had biopsy of lymph nodes at some other outside hospital previous to this. So 2 in 2 weeks.
Yeah.
This one I just saw the other day, and this guy's a few weeks post median sternotomy, and he has one of these kind of hybrid, and it's Intuity valve or Integrity, I can't remember the name, but it's kind of it's a stented bioprosthetic valve. It almost looks like a TAVR with valve leaflets in it, but they do this through a median sternotomy, and over the last couple of days he has started developing drainage from his sternal wound. And what's interesting in this case, and obviously mediastinitis and sternal dehiscence we worry about, even over the course of 4 days, you'll see that this guy's sternum the manubrium has started to separate a little bit more. This is over 4 days. You can see there's a little bit bigger gap in the sternum than there was. And I was just going through this and saw that there's some fluid in the anterior mediastinum. There's this little discrete collection here, a little bit more anteriorly. And of course, mediastinitis and sternal dehiscence in particular is something that we often can see in retrospect on radiographs that may not be prospectively picked up. But it wasn't until I was looking at the sagittal on this that I noticed something else that was peculiar. I was just looking at bone windows, and I saw this, which just happened to catch my eye, and it looks like a screw, as you can see right here. And this guy has a reconstruction plate in his sternum, and that screw wasn't there in the mediastinum 4 days ago. And when you look at the radiographs, and I'll show you some NPRs that I made, you can actually see, let me get rid of that. Yeah, between 4 days, the prior, you can see there is still a screw in that portion of the reconstruction plate And on the radiograph done the same day as the CT, I mean, this is not something that I would even think about looking for prospectively, but you can see that screw is missing. So on these MPRs that I did, this is on the prior CT, you can see that it's starting to back out. But what's really bizarre is the fact that this had to back out anteriorly and then somehow meander its way through the, sternal defect into the anterior mediastinum and then get to there. So, and I talked to the surgeon. He said the reason he put that plate in the manubrium was that it was kind of soft bone to begin with, but this is, a very subtle but interesting case of developing mediastinitis and dehiscence with a migration of the screw over just a couple of days.
So is it chicken or the egg? So the mediastinitis led to that loosening and the migration, or do you think the screw is the cause of the inflammation in the mediastinum?
No, well, he's got pus draining from the wound, so it's infected.
Oh,
so I think it's more of the infection led to the loosening of this.
Right. Okay.
Yeah, and the separation. But it's fascinating because it would have had to back out into the subcutaneous tissue, then migrate its way into the mediastinum.
Gosh, yeah, that's really odd.
Yeah, I know. And I was like, almost ready to finish my readout on this case with the resident when I was looking at the sagittals, and I was like, oh, that looks weird there.
Like a pus river, like a flow.
Okay, this one, I don't have a radiograph, but you can see, yeah, I heard Howard audibly gasp here or something. What do you guys think of this?
It's bad. What is going on?
There's a lot of bowel up there, which isn't good.
Right.
So I don't know if that medial stuff is like liver. That's the dense stuff is all liver, and that's just all bowel next to it. But
and so why would that be? This is an adult. He didn't have a congenital diaphragmatic hernia.
He's got trauma or something. I don't know.
This is the clue. So apparently 20 years ago or more, this guy was in a bad crash. And this is now, this is, in my book, the world's largest traumatic diaphragmatic hernia I've ever seen. And what's amazing is he really has had significant worsening of symptoms only over the past 4 or 5 years. You can see this is 2016. And you'll see, here's the diaphragmatic hiatus. You can see the cruce here. And then this is all just lateral, and you can't really see, you can see part of the diaphragm here. So obviously there was a huge traumatic diaphragmatic rupture, and the entire liver, portions of stomach, bowel, everything are up there. And you can see, another clue, it's not a congenital diaphragmatic hernia, he actually has developed right lung. Now, this was more recently worsening shortness of breath. And this was presented at a pulmonary conference, and we were discussing it. And it was interesting that some of them were skeptical that this might actually be the cause of his symptoms, which was a head scratcher for me, because I don't know. He's got increasing mass effect and mediastinal rotation and worsening atelectasis of this right lung, not to mention just like the distortion of you can see his IVC, his hepatic veins almost do like a U-turn right there. So, and you can see there's just no diaphragm here peripherally. So you can see a little bit of diaphragmatic slip there. So, they are going to talk to a surgeon, because I think if it's chronic, there is a reasonable question like how much of this lung function will regain. But unlike a congenital diaphragmatic hernia, it just looks like there's atelectatic lung under here. And certainly patients improve with repair of other types of hernias. So what do you think? Symptoms get better with treatment?
I think you should find some surgeons that are not as wussy as the ones who are skeptical about the effect of this on lung function.
It wasn't the surgeons, it was the pulmonologist.
This is affecting the left lung function too.
I know. That's what I said.
Maybe it's the small mucus plug in the bronchus intermedius. Did you tell
what
him?
it is.
Send them to bronch there?
No, I think that's a little bit of EDAC right there.
Oh, okay.
No, it's just Boeing. Yeah, Right. Yeah, I don't know. I was kind of entertained when they were, this can't be quantified in terms of numbers, right? Other than PFTs that they don't, they do get too caught up in their numbers rather than just the big elephant in this guy's chest.
Was all this debate among the pulmonologists?
What's that?
Was the debate among the pulmonologists?
Yes.
Yes.
No, it was there were no surgeons involved at that point. This guy will get operated on.
When I first came to UW, one of the senior thoracic surgeons, would just shake his hands at some of the theories that pulmonologists had. He says, David, you have to realize these pulmonologists, they have never seen a lung. And, that's the case.
Yep. Well, that was pretty impressive in my book. And then I'll just finish with this one. So this is a guy, you can see he had neck pain and throat swelling. And this was a couple weeks after cervical spine fusion. Corner shot on the chest radiograph. What is this? Is this some dilated laryngeal ventricle or something? And then you can see on the cervical spine radiograph performed at the same time, I didn't include the lateral, but I think the answer to that is no. You have this massive dilated air-filled thing in the neck. He may have had dysphagia as well, well, he definitely did. He may have said he did or not, but you can see what this is an enormous esophageal, perforation with this big, nearly cutaneous fistula. And some of this is surgical material, but some of this is oral contrast just filling this. And so this was iatrogenic. I don't know if the rupture happened during the procedure related to some sort of intubation, whether there's some mechanical effect from the fusion plates that were put in there, but this was just a couple of weeks after. So pretty dramatic presentation of an esophageal perforation.
Gosh, yeah.
Yeah, so it's just interesting imaging and a nice corner shot on the radiograph. I've got nothing more intelligent to add than that. So
what did they
I'll stop
do?
there, Jeff.
Did they do anything for it?
They put a drain in it, and the plan is to eventually repair it. So.
Okay. Cool.
All right, I will stop.
Okay. Who would like to go next?
I got some cases.
All right.
One second, I'm not even sure which screen this is. That is screen here. Here, all right. Sorry, where did my Terra Recon just go? All right, so this is a interesting case just because I had not seen this before. And I showed a weird breast implant thing the other day, but this is another strange breast implant thing. So this is a woman who has this avidly enhancing big right hilar mass. Young patient, I think in her 30s. I think, there's a differential for this. It could be Castleman disease, which was what I was hoping it was when I first came across it. But in fact, it was just a very large carcinoid, which the patient underwent a pneumonectomy for. So here's her kind of post-pneumonectomy radiographs. You can see standard looking pneumonectomy, a lot of deviation as the mediastinal structures are kind of filling that empty space. So she was complaining of a lot of symptoms related to shortness of breath. And you can see that basically the whole mediastinum is over, which is pretty typical. They diagnosed her with post-pneumonectomy syndrome, which is, compression and narrowing of the left main stem bronchus as it crosses between the spine and the pulmonary artery as it kind of goes back over to the mediastinal shift. Now, she didn't have any narrowing whatsoever, but she was quite symptomatic. And, they didn't know what to do with her. So they actually, you can see this is, let's see what this. So what they did, which was quite interesting, is you can see that there's now this material in here. And these are actually soft tissue expanders like they use for breast implants. And eventually they replaced those soft tissue expanders with actual breast implants. And here's her follow-up CT, which I actually just did a sniff test on her, where she now has breast implants in her pleural space to resolve the mediastinal shift. And it's actually pretty smart. I had just not seen that tech, and she did improve symptomatically. Although I did do a sniff test on her, and she was complaining of shortness of breath, and was convinced her diaphragm on the left was paralyzed, which it wasn't. So has anyone seen breast implants put as a space occupying lesion for post-pneumonectomy syndrome?
Yeah.
Yeah.
Our surgeons,
Yeah.
they prefer tissue expanders because they have a little bit more adjustment they can do till they get it where they like it.
Okay, well, never mind then. I guess
It's a good trivia question. It's a good question to ask the residents too. You know, what thoracic disease can you treat with breast implants? So
yeah, no,
I've seen a couple of cases.
yeah, I don't think I've seen it before. Okay, so this is a cool case because it kind of relates to stuff. So this is a guy who, soldier, the day before was running, he runs about 7 to 10 miles a day. His next morning, you know, he runs all the time, but anyways, he was fine. And then next morning he was somnolent. His friend couldn't wake him up. You can see that there's just kind of diffuse perihilar, or not diffuse, but perihilar areas of consolidation. And he's intubated, he's not doing well. And, you know, they thought he had a massive aspiration. The CT was read as having massive aspiration. He was kind of going downhill. They actually treated him with ECMO. And then here's his outside CT. So the clinicians came down and said, "Hey, can you look at this thing?" And I said, "Sure," and looked at it. And they did a bronch, and he had areas. It wasn't. They said it was hemorrhage, but there was definitely hemorrhage there. It was kind of like DAH, but it wasn't as severe as a lot of cases of DAH. And you can see here that there is, there are definitely findings that you would see with hemorrhage. A lot of that interlobular and intralobular septal thickening, that crazy paving pattern, a lot of basilar consolidation, which you can see with bad cases of DAH. But one thing I kind of noticed was that, it really had pronounced sparing of the subpleural portions of the lung, not just peripherally, but also centrally. And then, kind of that finding where you get this sparing around the peribronchovascular interstitium. And so I asked so they started treating him with steroids once they made the diagnosis of DAH, and he was getting a lot better by the time I saw this CT. And I said, and they were treating him and all the ANCAs came back negative, everything came back negative. And I just said, did he vape? And they're like, well, we don't know, let's find out. So by the time we saw him, he was actually extubated, but he was put on ECMO. And it turns out that whoops, that's not the right series, that the night before this all happened, he doesn't usually vape, but his roommate, the one that brought him in and called the ambulance, he was vaping from his vape pen, some form of THC substance, and developed this. So, it's hard to prove, but this is presumably some form of EVALI. We definitely have seen plenty of cases of pulmonary hemorrhage with EVALI, but this is presumably some form of EVALI.
So Seth, was he vaping himself, or was this secondhand vape?
No, vaping himself.
Okay.
Yeah, he was vaping himself.
Seth, if you remember, one of my cases was a pulmonary hemorrhage from vaping.
Yeah,
it was the first one I saw. Was it. So, in our series of patients, though, I think that was a very small number had hemorrhage.
it is. It's I don't know. I think in our larger cohort, we have about 5 or 6 out of like 150 or so that have hemorrhage, but definitely reported.
How many negative COVID tests did he have?
3.
Only 3.
3 negative COVID tests, and but they said he's still kind of you know, because again, yeah, it's hard to confirm, but everything else has come back negative. And he did give that when he kind of woke up. It's like, yeah, I was vaping. You know, it's funny. I was vaping my buddy's stuff. I don't usually vape, and we were just hanging out, and that was it. So maybe that was the cause.
I just chatted out a link, or put a link in the chat to an article I just came across talking about, you know, smoke. It's just a survey, but smoking, e-cigarette use, and coronavirus, and finding at least people that completed the survey that was there's a 5 times higher association for vapors having COVID. But who knows if that's causal or if that's just they're just engaging in other risky behaviors.
Yeah, exactly. They're hanging out with one another, smoking and doing other stuff.
Yeah.
So this is an interesting case because, anyways, I'll go to the final study. This is a case from 2005. You can see, I mean, beautiful subpleural sparing in this patient with fibrosis. Has some interesting cystic change. So here is the final study before the patient underwent. So the patient underwent an open lung biopsy back in like 2005, 2006. And what they noticed is that there were findings that were reminiscent of UIP, but it was very interesting because the fibrotic changes were really around the airways. So they weren't around the, you know, they weren't subpleural, they weren't paraseptal, it wasn't around the periphery of the lobules. So remember that not only is UIP involved, start in the periphery of the lung, it also starts in the periphery of the lobules, but this was in the center, but it was these dense fibroblastic foci, and they're obliterating out these airways. So here's the patient before she underwent transplant. And again, striking subpleural sparing, but I don't know if I've ever seen a case that really looks like UIP. And I mean, obviously it's not, but if you choke, let's put it, I've never seen a case that looks like such exuberant honeycombing. Yes, some of these are probably emphysematous spaces, but areas of exuberant honeycombing within a kind of NSIP distribution of fibrosis. And it's interesting because, you know, when this patient, and she has a collagen vascular disease, and then when she underwent her explant, they, again, read it as, you know, it's kind of weird. It's not typical. There's some definitely areas of that look like UIP, but it's in a strange distribution, and a lot of it looks like fibrotic NSIP. But
we had one transplanted just a couple weeks ago, almost identical to this. You know, because it's like, also, are these just cysts? You know,
right.
And because they're along the airways and not, you know, not traction leading to honeycombing.
Well, some of them you wonder, right.
Yeah.
Well, here, I mean, you wonder like, okay, here's this bronchiectatic thing, and there's like a little cyst coming off the edge. I mean, it's always hard to tell.
Right.
But I mean, I think if any of us, if we put some of the cystic stuff and we put it out a little more peripherally, but I just thought it was how interesting it was that these fibroblastic foci were so bronchiocentric on the pathology, and which is very atypical, and they were shocked by that and how it led to this cystic change. If it's post-obstructive, that's leading to this, like maybe LIP, where people think it's post-obstructive, or some post-obstructive change. I just hadn't seen a pattern like this before, really.
Seth, was she a smoker? I mean, if it's airway centric,
no,
never a smoker.
Never. Young woman, never a smoker.
Not smoking marijuana or anything like that.
Okay. I mean, at least per history, she was very adamant that she was never a smoker.
Okay, what was her collagen vascular disease? What did they call it?
Unspecified. No specific antibodies. I mean, there were a lot of things that were severely elevated. She had autoimmune hepatitis. She had a lot of like non-specific things, like her ANA was super high. Her anti-smooth muscle antibody was super high, but nothing else. No specific antibodies for like your, double-stranded DNA and your, Sjogren's antibodies. None of those were positive.
With the autoimmune hepatitis, it wasn't IgG4 or anything like that.
I don't know. I mean, it may be this patient underwent transplant in 2011, so I don't know if that was really kind of wasn't on the. They just, I don't know.
Okay, I would not call this honeycombing. It's just in the wrong distribution.
No, I wouldn't either. I'm just saying, in these areas, I mean, it really, if you put this out another few millimeters, most people will call this honeycombing. I agree. I wouldn't call it honeycombing because it's not in the right place for it.
Got it.
But pathologically, it was honeycombing. That was what was interesting. Pathologically, around the airways, they saw honeycombing and the fibroblastic foci. So it's just a interesting case. And this is nothing. This is just a pretty case that just came in, and I don't really understand why this patient went such an extensive workup. They came in from the outside, had a pretty slam dunk diagnosis. I had the chest CT, which is quite nice, or the chest X-ray. And for some reason, they were concerned or convinced that this thing was invading the heart. And I tried to convince them that these things don't invade the heart, but they didn't believe me. So they wanted a study, they wanted MRI, and like, just get a CT. Yeah, a little bit higher radiation, but man, because there's no doubt this isn't invading the heart. This is a nice teratoma. And I actually find gated CT to be very, very good for assessing for cardiac invasion. Yeah, MRI is probably better. MRI is a little bit bigger of a pain in the ass. And when you have such a low index of suspicion with this teratoma, I think it's very nice to where you can just show that the pericardium and the heart, don't really see the pericardium well, but if the heart is moving, sliding adjacent to this, you got to imagine that the epicardial fat and the pericardium are as well. So this is just a teratoma. And of course, as I said, as you imagine, there's not going to be any cardiac invasion with this thing. So they you can see here, they biopsied it. There's some, I'm like, just take it out if you even want to take it out. But anyways, that's it.
Hey, Seth, is that a GE Revolution scanner, or what scanner are you doing that 4D CT on?
That was a GE.
That looks really good. Yeah. We had trouble with some of our 4D on that. I don't know what our protocol is. I can't get them to look this good.
Well, it's nice. I don't know. We just did it. I told them, do it. You have to do it in 2 slabs. And I just said, make sure that, and if someone is small enough and has a small enough chest, you can literally just do it all in one big slab. And, we're able to get the mass in a single 6. You can actually we didn't. She cut right through it. You can see the little bit of the stitching artifact right through the middle, even though I told her to. Anyways, but looks good. Yeah.
That's a really good use of the cine though on CT.
I've used it for thymomas. And sometimes you see it, you see the pericardium as the heart contracts, you actually see the thymoma pull with the cardiac contraction. You're like, it's tethered. It's either invading the pericardium definitely, and they'll say, okay, we're going to need a cardiac surgeon to scrub in, because they're always sometimes a little hesitant to muck with the pericardium and heart. So I find it's a good use. Jeff, those are my cases.
All right, that's an awesome case. Thanks. I was going to say I've seen a couple cases of connective tissue disease with funny-looking cystic stuff, antisynthetase syndrome and a systemic sclerosis, but I don't think we ever had tissue confirmation of what it was. I just assumed they were cysts, but that's interesting. Yours were actually honeycombing, and message.
And they specifically said it's all peribronchiolar, like all the findings of UIP were in the exact opposite distribution of where it should be. Because even on the lobular level, it was exactly in the wrong place.
And Vascular,
I've got one almost identical to that. I pulled up, I can show that also has histology from transplant if you want me to show it really quick.
Yeah, and Vasilius just messaged me saying that they had a similar case that had subpleural sparing that had UIP on the final diagnosis in the setting of connective tissue disease. So another complex thing. Okay, Travis, you said you had a case. So
yeah, I can show it really quick.
Okay.
Yeah,
Seth,
this is not the.
Sorry, Seth, your patient didn't have Sjogren's as part of her syndrome, did she?
No. Okay. Every specific, like Sjogren's antibody, scleroderma, all that stuff was negative. Smooth muscle antibody stuff was all negative. I mean, for myositis, dermatomyositis was all negative.
This one's interesting because you can see there's this bronchiolocentric, just like little ground glass and a few little foci of traction and maybe small cysts. And then you get into the lower lobes and you can see how just, it's more of a central axial distribution with some areas of subpleural sparing on the left. But, Seth, like you're saying, some of these areas creep out here on the right. And if you're just looking in that area, you'd be, you'd be wanting to call this UIP, but it's too diffuse in the axial plane or too central, I think. But this one, some of this is traction. Some of these, I think, are more discrete cysts, especially in this right lower lobe. And then on path, the explant, you can see, they called it, just interstitial fibrosis with bronchiolocentric.
Exactly. Yeah.
Right. And so there was another one a couple of weeks ago that the pathologist said was a mix of UIP and an SIP. I think he just called this fibrosing and SIP, knowing the patient, she's been diagnosed with undifferentiated connective tissue disease based on the CCP antibody. So she's kind of one of these ones that would fall into the IPAF right now.
But it's so interesting because this woman has, they're calling her, it doesn't matter, if they're calling her IPF, you look up her history of IPF, and you're like, oh my God, drives me nuts.
Right, exactly. And that's the point, right? Yeah, that it's not.
Because her history is, it's UIP and pathology, it must be IPF. You're like, oh my God, just stop.
Like, no, yeah. Now that doesn't mean, I don't know, we've got these ongoing trials with antifibrotics in connective tissue disease. We'll see.
Okay, who's up? Howard or Peter, David?
I have a few, Jeff.
I remember we went back sometime this past year, 500 consecutive case D protocol. Positive rate was only 4%.
Okay.
Terrible. Not even witness that, we write 96% of the time.
All right, so this is a young lady in her early 20s, and a few years ago she presented with a peritonsillar abscess. She got a neck CT, and on the neck CT they incidentally saw a mediastinal mass, so they referred her to, so they got a chest CT to follow that up. So let me just pull up.
Are they still there?
Yes, it was in 2019. So this is the CT we have of this mediastinal, and it looks like kind of ill-defined, low-density mass here. I'm not sure. I think it was just kind of read as a non-specific lesion recommended. Because the surgeon, the thoracic surgeon, looked at it, and he thought it was a duplication cyst or some other benign mass, and decided to follow up, not to operate. You can see there's other lesions here in the mediastinum. And this is a follow-up CT earlier this year, and it kind of looks stable. And the interesting findings are on the MRI here. So we recently looked at an MRI of the chest. And let's show the T2 weighted sequence.
So as far as the main thing, rule out P.
So we have these multifocal mediastinal lesions. They're right on T2. Low signal on T1, and then no post-contrast enhancement. I'll show the subtractions here. No enhancement. So we thought this was lymphangiomatosis. And you can see it also outside in the soft tissues. There's involvement in here right adjacent to the pericardium. There are lesions.
On the neck of it, she has the terminal
and then the upper extremity as well. There was no, so I looked at a head CT. There's no bone involvement. So I know we've shown Gorham syndrome before. Somebody else showed it before, I remember a while ago. That can go along with the spectrum.
Yeah.
But lymphangiomatosis.
The majority are the left upper lobe. The upper portion.
All right. This is a good example. So this is a good example, and I'll show the CT. So this is the current CT, and then this is the prior CT. Let me pull them together.
So there's a lot of spottic.
So on the left, we have a CT from 2012, and on the right, from 2019. So this is just a good example of nodular parenchymal form of amyloidosis. This patient just has a history of diabetes, end-stage renal disease, but no systemic, there's no history of any systemic reason for her to have amyloidosis. And then it just seems like it's just confined to the lung. So presumably some kind of primary pulmonary amyloidosis. No plasma cell dyscrasias.
Doesn't have Sjogren's syndrome.
No evidence of Sjogren's.
Okay.
And it's kind of a good example of how it's relatively stable over long term, not a lot of symptoms, and kind of just idiopathic.
It's interesting. I've seen this. I don't think I've seen a case of parenchymal amyloid like this, the kind of nodular with the cysts, that's been associated with systemic disease. I'm sure it's happened, and I'm sure but in most cases, it's a unrelated finding. I don't know what other people have seen it with systemic amyloid.
Agree, or with Sjogren's syndrome, and it's
or Sjogren's, with Sjogren's, but
part of the sort of LIP spectrum. Because if you took away the nodules, you would just call this LIP.
Yeah.
So,
yeah, and this was actually
he's shown cases like this before.
Yeah.
I think certainly not with multiple myeloma, just based on survival. Patients probably don't survive long enough to where that actually, can manifest.
So that's actually part of the literature that the nodular basal primary lung amyloid is not associated. I shouldn't have said primary. The lung amyloid is usually not associated with systemic disease. So it has a benign prognosis. We followed a woman for like 18 years who had cysts and these ossific masses in her lung bases.
And so these are ossifications, right?
Yes.
Okay. Yeah, and this was actually biopsy proven back in 2012 at an outside. I don't have the path, but it was done elsewhere. But about biopsy proven pulmonary amyloid.
Beautiful case.
Thank you. All right, and then two quick ones. This is just a good example of something we saw yesterday, and I will show. So this is the prior scan from June. So here's the chest CT, and then we can see in the aorta there's this crescent of low density. I think this was an acute presentation. And so this is a good example of a intramural hematoma, and you can see it's type B. It starts in the distal arch, and then it goes essentially to the renals. It doesn't go below the renals as we would expect with a intramural hematoma. And yeah, so this is still the prior from June, and I'm going to show the one I looked at yesterday with one of our residents. Is an interesting case of how it evolves. Sorry, so this is the new one. So this was called a, even though it was read correctly on the initial scan, as a intramural hematoma. For whatever reason, the surgeons just called it a type B dissection in their notes, but that's not what that is. And then, so this is the follow-up 2 months later, and you can see how it's a nice example of intramural blood pools that have developed within the IMH. And then there's also a good example here, what's been described in the literature as ulcer-like projections here. So you can see the mouth of this lesion here is not small like the blood pool. So these are actually things that these are abnormalities that have potentially a bad outcome. Recommendation is to be surgically managed for these ulcer-like projections, as opposed to the multiple blood pools, intramural blood pools here.
Right, it's nice because if you go to the intramural blood pools, if you go back to that, will have a very, very, very thin connection to the underlying aorta, and a lot of them are fed by either lumbar intercostal arteries, or almost like endoleaks in the false lumen.
Yeah, and then you can actually see that on this. You can see it right there, for example.
Yeah, and the ulcer-like projections are wider mouth and actually more conspicuously attached to the lumen. And the way you differentiate them from penetrating ulcers is the fact that they're occurring in areas that are relatively devoid of atherosclerotic disease.
So yeah, and then the other thing is they weren't present on the prior study from 2 months ago. This is the best example of the ulcer-like projection right there.
You know, right. No, but if you have it like just a patient coming in for the first time and you don't have a study and you see kind of result image, but that's a really nice classic progression, and showing both in the same person is good. And you're right, the ulcer-like projections are associated with increased mortality and rupture and other stuff.
Mm-hmm.
Yeah.
Very good.
And then one last one, and I think I know Travis had a really nice presentation on this, so I'm gonna defer to his expertise if he has anything to, but I'll just show the case. So this is a patient that has cryptogenic cirrhosis, and here is his, I'll just show his abdominal MR just for his cirrhosis. And here's his lung. Here's his lungs. This is from 2017, so this is the initial scan. So some peripheral, looks like early, probable UIP here, not definite honeycombing of the peripheral reticulation. And just show some follow-ups.
Peter, I've got a case just like this. I'm waiting for the genetics back on it.
Yeah.
That's awesome. Yeah.
So yeah, so this is 2019. So it's getting worse. And by the way, this patient has his father had pulmonary fibrosis also.
Does he have anemia or other thrombocytopenia?
I think he did. I think he did actually. Yeah. And then so this is his most recent. So you can see
So I have 3 of these cases, and it's all telomerase. I haven't seen it with surfactant mutations,
and
which makes sense.
And so he got sent for. So here's his lab work. So he falls in the. This is the telomere length. So he falls in the first percentile line.
Yeah, less than 10th.
Less than 10th, yeah.
Yep.
He didn't follow up with his genetic testing though, so we don't know about any mutations. But yeah. Oh, the other interesting thing was he has well, there's a good thing to show, I guess. He has hepatopulmonary syndrome, so you can see his especially down here, I think is a good example of that. You can see his pulmonary arteries coming down towards the periphery.
I think it's just, it's important in these cases to look at the liver, and if you see something, in our case, they hadn't done a genetic workup yet.
Yeah, so this guy actually, so he wasn't able to tolerate any of the, he was diagnosed with IPF, but he wasn't able to tolerate any of the antifibrotics or the CellCept, suppression. There's too much nausea. So he just getting worse. And I think that was my last one.
Great cases.
Thanks, guys.
All right. Howard, did you have any cases?
I've got two. I can show them or next week, whatever you like.
We've probably got time for two.
Okay.
There you go.
Yeah, these two cases are really particularly good for trainees. So let me start with this one. This is a patient that came to the ER recently, and the impression pretty much seemed to be directed towards a COVID negative statement, and just left it at that. But it's still pretty abnormal. So the heart is a little bit big, but I think the biggest finding, one that's easy to go by, is to look at the pulmonary vessels. And if you do that and you compare side to side and superior to inferior and central to peripheral, you'll see pulmonary arteries here, here, and there. But conspicuously, looking elsewhere in the lungs, you don't see vessels. They're very, very attenuated or apparently missing. Perhaps if I change the window, you might be able to intuit that this area of lung is blacker than this area, but particularly up here. So we have that finding. So central pulmonary artery dilatation, very attenuated pulmonary vessels, a pattern, and the inference is mosaic oligemia. And for sure, no surprise that he has massive pulmonary embolism. So very substantial dilatation of the right atrium and right ventricle. On ultrasound, this is the only one that I could kind of interpret. He has very poor contractility of the right ventricle. There's pressure overload of it. So imaging findings that are easy to go by, but massive pulmonary embolism. So he required thrombolysis is what they started with, and they were hoping that would be sufficient, but he did rather poorly. And then I think on the next day, he coded pulseless activity. They had to institute emergently VA ECMO and do a surgical embolectomy to save his life. So dramatic vascular findings that are easy to go by. The next one also is interesting. So here is a patient, the kind of case we see on a daily basis. We have nice findings of interstitial edema, particularly in relation to septal lines in the lungs. We have a big heart. So we're thinking hydrostatic lung edema, left atrial hypertension, straightforward case. One would think of, certainly with a heart like this, of a cardiomyopathy, ischemic or not ischemic. And in terms of heart disease more generally, with respect to valvular disease, see what the heart looks like on the lateral. If one looks at this to look for left atrial enlargement, because I often find people think of mitral valve disease only as a potential cause of left atrial hypertension. The lesson here is the aortic root and the proximal ascending aorta are buried in that mediastinum. And even if they're very abnormal, you may not be able to see it. And this degree of dilatation, easy to go by. So that's the finding of the aortic root. Now, as you might suspect, with that aortic root, he has aortic valve regurgitation as the cause of that left atrial hypertension. That's exactly it. And the surgery, of course, will be replacement of the root with a valve conduit, so a Bentall procedure for that. So the very, very dilated aorta in here, very hard to appreciate. So just a nice teaching case, particularly for residents, to think of the aorta as well, not just the mitral valve.
Excellent. Both.
All right, Jeff.
All right. Well, thanks, everybody. We will continue next week. Talk to you later.
Thanks.
Thanks, everyone.
Thanks.
Bye.
Thank you.